Welcome to this Step 2 clinical knowledge review on vascular surgery test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for vascular surgery and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the surgery and vascular sections of first aid and your question bank before or alongside this video. Here is what we will cover in this video. First, we will learn to recognize the high-yield question stems for vascular surgery topics that appear on Step 2. Second, we will apply specific test-taking strategies for abdominal aortic aneurysm, carotid artery stenosis, acute mesenteric ischemia, and compartment syndrome. Third, we will master the next best step question format for vascular surgical emergencies. Before watching this video, make sure you have reviewed the surgery chapters in first aid and worked through vascular surgery questions in your question bank. This video is about strategy, not reteaching the material from scratch. Our first strategy is the emergency versus elective split. When you see a vascular surgery question, the very first thing you should do is determine whether this is an emergency or an elective scenario. Emergency presentations will have sudden onset pain, hemodynamic instability, or signs of rupture. The classic board question for a ruptured abdominal aortic aneurysm gives you hypertension, a pulsatile abdominal mass, and severe back or flank pain. When you see that triad, the answer is emergent surgical repair, no imaging needed. On the other hand, if the patient is stable and the aneurysm was found incidentally, you need to know the size thresholds. Elective repair is indicated when the aneurysm exceeds 5.5 centimeters or is growing more than half a centimeter over 6 months. Below that threshold, the answer is surveillance with serial imaging. The boards test this distinction frequently. Strategy 2 is distinguishing acute from chronic ischemia. This is critical because the management is completely different. In acute mesenteric ischemia, the classic buzzword is pain out of proportion to the physical exam. The patient is screaming in pain, but when you press on the abdomen, it feels soft and non-tender. That mismatch should immediately trigger you to think acute mesenteric ischemia. The boards will often include a history of atrial fibrillation or a recent cardiac event as the source of the embolus. In contrast, chronic mesenteric ischemia presents with intestinal angina, which means postprandial pain, food fear, and significant weight loss. For peripheral arterial disease, remember claudication progresses to rest pain and then non-healing wounds. Review the ankle brachial index values in your surgery references so you know the cutoffs for mild, moderate, and severe disease. Now let us go through the high-yield stem patterns you will encounter. For abdominal aortic aneurysm, the classic stem is an elderly male smoker with either a pulsatile abdominal mass on exam or an incidental finding on imaging. If the stem gives you hemodynamic instability and back pain, that is rupture, and the answer is emergent operative repair. If the patient is stable, focus on the diameter to decide between surveillance and elective repair. For carotid stenosis, you will get a patient with neurologic symptoms like a transient ischemic attack or sudden monocular vision loss, called amaurosis fugax, plus a carotid bruit. The key is the degree of stenosis, which determines whether the answer is surgical intervention or medical management. For compartment syndrome, the stem gives you a post-fracture or post-reperfusion patient with severe pain, especially pain with passive stretch and a tense, swollen limb. When the clinical picture is clear, the answer is always emergent fasciotomy without delay. Let us work through our first practice question. Read this carefully. We have a 68-year-old male smoker with hypertension who comes in with sudden severe back pain, lightheadedness, hypertension, diaphoresis, and a pulsatile abdominal mass. Take a moment and think about what pattern you recognize here. The answer choices are computed tomography angiography, emergent open surgical repair, abdominal ultrasound, or fluid resuscitation with serial exams. Think about what you would choose before we walk through the answer together. Let us walk through this answer step by step. Step 1. Spot the pattern. We have an elderly male smoker with sudden back pain, hypertension, and a pulsatile abdominal mass. This is the classic triad of a ruptured abdominal aortic aneurysm, and you need to recognize it immediately. Step 2. Apply the rule. The board rule here is straightforward. A hemodynamically unstable patient with a suspected ruptured aneurysm goes directly to the operating room. You do not stop for imaging. Step 3. Eliminate wrong answers. Choice A, computed tomography angiography, would be appropriate if the patient were hemodynamically stable, but this patient has a blood pressure of 80/50. Choice C, ultrasound, is a screening tool not appropriate in an emergency. Choice D, fluid resuscitation with serial exams, is too passive for a surgical emergency. The correct answer is B, emergent open surgical repair. Review the vascular surgery chapter in your surgery references for more detail on the management algorithm. Here is our second practice question. We have a 72-year-old man with multiple vascular risk factors who had a transient episode of right-sided weakness and speech difficulty that resolved within 30 minutes. This sounds like a transient ischemic attack. On exam, there is a left carotid brute, and duplex ultrasound shows 75% stenosis of the left internal carotid artery. The question asks for the most appropriate next step. Think about what you know regarding symptomatic carotid stenosis and the indications for surgical intervention before we go through the answer. Let us walk through this one. First, read the question carefully. We have a symptomatic patient, meaning he had a transient ischemic attack and his carotid duplex shows 75% stenosis. For the boards, the key rule is that symptomatic carotid stenosis of 70% or greater is an indication for carotid endarterectomy. This is a must-know threshold. Now let us look at why the other answers are wrong. Choice A, aspirin and statin alone, is medical management. That is appropriate for asymptomatic patients with less than 60% stenosis, but this patient is symptomatic with high-grade disease. Choice C, additional imaging with computed tomography angiography, is unnecessary here because the duplex already gives us the diagnosis. Choice D, repeating the ultrasound in 6 months, is a surveillance strategy that is inappropriate when the patient has already had a neurologic event. The answer is B, carotid endarterectomy. Remember, for asymptomatic stenosis, the threshold is higher, typically 60% or greater, with additional considerations. Review the carotid stenosis management algorithm in your surgery review materials. Now let us cover acute mesenteric ischemia management for the boards. The most important thing to know is the etiology, because it changes the management. Arterial embolism is the most common cause and is usually from atrial fibrillation. These patients need emergent surgical embolectomy or endovascular intervention. For a stable patient, computed tomography angiography is the diagnostic study of choice. Elevated lactate and metabolic acidosis are late and ominous signs indicating bowel necrosis has already occurred. For the different etiologies, remember that mesenteric venous thrombosis is associated with hypercoagulable states and may be managed with anticoagulation if caught early. Non-occlusive mesenteric ischemia happens in critically ill patients in low-flow states and is treated by addressing the underlying cause and improving perfusion. The boards love testing these distinctions, so review the mesenteric ischemia section in your surgery references carefully. Here is our third practice question. A 75-year-old woman with atrial fibrillation and heart failure comes in with sudden severe abdominal pain. The key finding here is that her abdomen is soft and non-tender despite her severe pain. She also has an elevated white blood cell count and elevated lactate. Think about what diagnosis this pattern points to and what the next best step would be before we review the answer together. Let us break this down. First, spot the classic pattern. Elderly patient with atrial fibrillation, sudden onset abdominal pain, and the critical finding of pain out of proportion to the physical exam. The abdomen is soft and non-tender even though she is in severe pain. This mismatch is the #1 buzzword for acute mesenteric ischemia. Second, know the key distinction. The elevated lactate is concerning for bowel ischemia, but her abdomen is still soft, meaning peritonitis has not yet developed. This means we still have time to get a diagnosis before going to surgery. Computed tomography angiography is the best diagnostic study because it can identify the vascular occlusion and assess bowel viability. If she had peritoneal signs like guarding, rigidity, or rebound tenderness, we would go straight to exploratory laparotomy. An abdominal radiograph does not have the sensitivity to diagnose this condition, and observation is inappropriate when the clinical picture and labs are this concerning. The answer is B, computed tomography angiography of the abdomen. Our final test-taking pearl is about compartment syndrome. This is a clinical diagnosis and a true surgical emergency. The most important thing to remember is that compartment syndrome presents with pain out of proportion and pain with passive stretch. These are the earliest and most reliable findings. Late findings like pulselessness and paralysis mean you have already waited too long. On the boards, when you see a patient with a tibial fracture, or a patient who just had revascularization of an ischemic limb and they develop worsening pain with a tense swollen extremity, the answer is always emergent fasciotomy. Do not choose observation, do not choose ice and elevation, and do not wait for compartment pressure measurements when the clinical picture is clear. Now, if the question specifically gives you pressure measurements, remember that when the compartment pressure is within 30 millimeters of mercury of the diastolic blood pressure, that is an indication for fasciotomy. This is called the delta pressure. Review the orthopedic and vascular surgery sections of your review materials for more detail on compartment syndrome scenarios. That wraps up our vascular surgery test-taking strategies. Let us quickly recap. For abdominal aortic aneurysm, know the difference between emergent rupture and elective repair, and remember the size thresholds. For carotid stenosis, remember that symptomatic stenosis of 70% or greater needs carotid endarterectomy. For acute mesenteric ischemia, pain out of proportion to exam is your number one buzzword, and computed tomography angiography is your diagnostic study of choice. For compartment syndrome, emergent fasciotomy is the answer when the clinical picture is clear. For study resources, review the surgery chapters in first aid and work through vascular surgery questions in your question bank. Make sure you also check out the vascular surgery sections of your other board review materials. For expert tutoring and residency advising, visit roadmaptoresidency.com. If you found this video helpful, please like, subscribe, and share it with your classmates. Good luck on your exam!